Welcome to tonight's masterclass. We have a great topic tonight. It's back pain, but we're going to address back pain from a new angle, which I think will create a masterclass where all of our attendees are going to learn something new, interesting, and perhaps, hopefully, something they can take back into the clinic. My name is Robin Young. I'm the founder and editor for Orthopedics This Week, and I'll be the moderator for tonight's masterclass. The topic, as I said, is back pain, but we're going to address it from the perspective of the facet joint. And the topic is going to be, how can we address facet-generated back pain? It's a very timely subject. And historically, low back pain has been thought to primarily be caused by disc degeneration. But there's a growing body of literature on the high prevalence and the role of the facet joint and facet joint degeneration as a cause of low back pain. So we organized the masterclass tonight in a kind of a unique way. We have two presenters from the company that designed the implant to address the facet pain, and then a physician who's been using the product in patients. So they'll be presenting on behalf of the company. And then we assembled a group of three really experts. We have an expert from the engineering perspective. We have an entrepreneur who has started several companies and has managed companies in the spine world and is now managing a venture fund. He'll be one of the questioners. And then finally, we have a practicing a spine surgeon. And so those will be we call them sharks, as in Shark Tank. They will be asking the questions of the management and the physician who's been using the product. So start with Dr. Thierry Dufour, who's a neurosurgeon at the Geoffroy Saint-Hilaire Hospital in Paris, France. And he's going to share his experience using, and the name of the product, by the way, that we're talking about to address facet joint pain is called the FFX, Facet Cage. And it's designed to address back pain and instability, and it has already been used successfully in Europe in several thousand patients. And then presenting on behalf of the company is its founder, its principal engineer, its CEO, and chief cook and bottle washer, Camille Srour. And the name of the French company that has put this all together, who has received, by the way, FDA clearance, is SC Medica. On our panel, our so-called sharks, we have Tom Afzal, who's the managing director of Galen Ventures. And again, Tom has managed and grown several companies over his career very successfully. Dr. Safdar Khan, who's a professor of orthopedic surgery, and he's the vice chair of surgical innovations, perfect for this panel at the University of California. And my dear friend, who I've known for, I think, 25 years, a research professor and executive director at the University of Utah Health, Wade Fallon. So this is a great panel to ask questions. And to kick us off, we do have a short video on this device, the FFX device, and how it works to address facet-generated back pain. Well, that's excellent video. I really enjoyed that. I hope you did too. Starting us off, presenting again for the company will be Camille Srour, CEO of SC Medica. He'll give us a little of the history of the project and the design of his device, the FFX device for addressing facet pain. Camille.
Today, I want to share the story of how we got interested in facet pain treatment. So no big deal, but just the unofficial behind-the-scenes story of how we got to design this device on the one hand, and how our thought process evolved in time around the indication for the device. Back in 2015, we at SC Medica were thinking of the following situation and we could say dilemma in some cases for surgeons. So for stenosis patient, for example, you have those cases where they're a little unstable. So it's not so unstable that you think that you should put pedicle screws without thinking, without a second thought, but it's not so stable either that you're very happy with decompression alone. And we're thinking that really for those moderate instability, in those cases where we could say there is the dilemma zone, maybe we could do better than having the two options of either putting nothing in place or having the rigidity invasiveness right away of pedicle screws for those moderately unstable patients. And while we were thinking about the options around that, we got more and more interested in what we consider a much undervalued part of the spine, small joints, the facet joints. And really, we thought, what if we could leverage this joint, who has a crucial role in spinal motion? What if we could leverage it to address the patient in this dilemma zone? And this got us to design what we have called the FFX facet fixation device. And really, I believe it's a unique device. So obviously, I might be a little biased, but I think it's truly a unique device because not only does it have the advantages of a cage, a spacer, like interbody cages, so we know it's very good in promoting bony fusion, but also we have the primary anchoring and the stability provided with this self-compressive screw that we add perpendicularly to the facet joint. And this is super important because with this trajectory and with this design, you get the best of both worlds. You get the spacer effect, the fusion effect, and also you get a very strong anti-migration and a very good primary stability provided by the compression of the screw. It is kind of sandwiching the cage. So this all leads to, for example, the following situation. On the left, you have a two-level spinal fusion with pedicle screws, and on the right, same two-level case with FFX design. So not only does it look very neat and much less invasive visually, but also our clinical data let us show that it indeed produced and induced a shorter OR time because of the simplicity of the technique compared to pedicle screw fixation. And this also came with a reduction of bleeding during the surgery. Also, we later also did some finite element biomechanical studies, and those suggested that because the fixation was less invasive, we had less adjacent level loads with this fixation method compared to pedicle screws. So this was for the biomechanical analysis, but this later confirmed in our studies where we ended up showing that for those patients in the dilemma zone, indeed we got less reoperation due to adjacent level degeneration. And last, in terms of clinical data I want to share today is that this technique also proved to have a very high rate of fusion defined as a bony bridge in the facet joints. And this is because we are rasping the joint, we are really preparing the facet joint for fusion. And then we have this self-compressive effect around the cage that really promotes a high rate of facet fusion. And because our system combines a cage and a screw, the spacer effect of the cage also opened the foramen to almost 4 millimeters. So this is, in 1 minute, really where we started and the clinical data we got. But I want to pause here for a second. After the few first 100 cases and 1,000 cases, at this point of the story, we got more and more feedback from our surgeon users telling us, you know what? When I treat a stenosis patient with this device, I can tell during the post-op consultation which one got facet fixation and which ones got decompression alone based on the fact they had important residual back pain or not. So this got us thinking, maybe there's something going on in the facets that is not only a question of stability, but also producing and generating back pain. And while we were thinking around that notion and thinking about that, I think there's a very interesting study that really can illustrate the point. And this was a 2023 analysis of a 25,000 patient study, a prospective one in the UK. And this study analyzed on this cohort the reduction or not of back pain in stenosis patient who got decompression alone. And long story short, what the study showed is that only half of the patients got a significant reduction in back pain. So how can we explain that? How can we explain those results? Where first, where does back pain come from in the stenosis patient? Probably it's not coming from the disc, because otherwise the surgeon would have treated the disc and would not be doing a decompression load if they thought the disc was a pain generator. So what does this leave us with? Well, there is the dura mater compression, but this is addressed by the decompression during the surgery. So how can we explain that half of the patients still have significant back pain? Well, probably this is coming from the facet joints. So today, and I really wanted to share with you how our thought process evolved. Today, in stenosis patients, we really believe there are three cases where the use of FFX fixation is fully beneficial for patients. So first, if you have some facet-generated back pain, also called facet syndrome. So how do we confirm that? So this can be confirmed by positive blood test, can be confirmed by some typical clinical signs like a peak of pain when you're putting your finger on a facet generating back pain. So that's one. Second, of course, is those patients in the dilemma zone that we talked extensively at the beginning. So patient with spondy up to grade 1. And last also are all those cases where, because of your decompression technique or the patient in question, you believe that you might destabilize the patient by doing the decompression. So let's say you're a surgeon, your typical technique is doing a full laminectomy, and on a patient you need to do a full laminectomy for 3 levels. You might fear that because of the decompression, you're inducing some instability that was not there before. So in those cases, you might want to think about a posterior fixation like FFX, which is a lightweight posterior fusion method to address those cases. And to conclude, and I'll finish on that, because we showed and talked about 2 aspects and 2 benefits of the techniques, both in terms of instability and pain treatment. Today, we really believe the indications are threefold. First, it can be for facet-generated back pain even before the stage of stenosis, so pure facet syndrome, we could call that. It could be, of course, for stenosis patients in the case we just talked about, the 3 cases. And last also, it can be very interesting as an adjunct to pedicle screw fusion because of the high rate of facet bone bridge you get with the technique. So you might want to maximize the chance of posterior fusion even with a pedicle screw system. So on that, I'll hand it over to Dr. Dufour, who will share his experience and a clinical case.
Dear Shark, dear colleagues, dear all, let me present you the Facet Fusion with FFX, a new device to treat facet pain with or without lumbar stenosis. I will share with you a clinical case for the beginning. It's a young OP nurse to start. She's 65-year-old. She's very thin, with bone mass index, non-smoker, low back pain for 1 year, with right posterior radical pain for a couple of months. Normal neurological examination, but high consumption of tablets, drugs, non-steroid anti-inflammatory drugs, and also paracetamol. If you look at the NMR, you can see there is a lumbar stenosis due to L4, L5 spondylo, grade 1, with no instability. If you look at the X-ray, dynamic X-ray on the next slide, you can see also bilateral facet osteoarthritis, a huge bubble from osteoarthritis on the right side and asymmetric osteoarthritis. And also foraminal stenosis, bilateral foraminal stenosis, a bit predominant on the right side. If you look at the dynamic X-ray, which is systematically done for this type of indication, to search of instability, here you can see there is no instability, but a spondy 4-5 grade 1. So if you look at the whole history, beginning of the low back pain was 2 years before surgery. And then you can have the first consultation, and you can see there is no neurological bad examination, but very low back pain with a Facet syndrome, which was described nearly 100 years ago by Vittorio Putti from Italy. And then we tried infiltration, which is in the aim to treat the pain before surgery. And the first one was very effective, but the second one only 1 week. So we decided to treat the Facet syndrome with FFR at the end of the November 2022, because due to the more frequent sciatic pain and also some paresthesia of the feet, which probably the nerve roots were suffering. Surgery. So what did I do? Simple. I began with the Facet's introduction in the Facet zone before screwing. Then after bilateral decompression from left to right, respecting the spinous process, but opening all the column, I mean. And then after, I put the screws in compression with from right to the left and from left to the right to be sure you are perpendicular to the facet and to the FFR. So what was the result? Clinically very simple. Discharge D1 without any pain anymore. It was like interrupter. You see, the light was on and then off. She had Mackenzie physiotherapy for 1 month and also a brace for 1 month. No more pain and very low back pain 6 weeks after surgery. So it allows her to have a nice travel in Japan with no limitation in activities and no complaints, no treatment. And 2 years after surgery, here are the results in terms of pain. No more leg pain and just only 1 to 10 for back pain. So it's very low pain, no more consumption of any painkiller or something like that, and the life is better. So that was a history for one of my very first cases, but with a long-term follow-up now, more than 2 years, it's okay. And it's my experience with this type of device, which is easy to implant and with a good results. Probably the most difficult at the beginning is to find or to keep in mind that this is a problem, facets, and facet pain is probably much more frequent in low back pain that we thought before.
So thank you, Dr. Dufour. That was really terrific. I'm going to start with Wade Fallon from University of Utah. And Wade, as you listen to the presentations and you consider this device to address facet pain and maybe more, what questions come to you?
Sure. Thank you, Robin. First, I just want to say congratulations to the SC Medica team for the innovation and the exciting outcomes from their 2-year follow-up clinical study. Very exciting to see those results. My first question relates to the finite element analysis study that was conducted. So in that finite element analysis, it suggests that there's lower adjacent level stresses, but higher level segmental motion at the index level for FFX compared to posterior rod fixation. Higher motion levels may compromise device fixation and stability. Given that there were 4 FFX device migrations at 2 years in your clinical study in France, what are the plans to protect against device migration in longer-term patients?
Thank you for the question, and I think you're referring to our two-year data. And in this cohort, we had some 10%, I think, of cages, facet cages that were put without the facet screw, and those were the ones where we got the few cases of migration. So per our IFU today, the use of the facet screw is mandatory, and we get no cases in our series or other of facet cage migration with the use of the locking screw.
And, do you have follow-up on that, Wade? If not, I'll go to Dr. Khan.
Yeah, no, that makes sense. Thank you for that answer, Camille.
Great. Dr. Khan, what questions do you have?
Thank you very much, Robin. And again, congratulations to Mr. Srour and Professor Dufour. Thank you for entertaining my questions today. I have a few, and some of them relate around the concept that we're talking around segmental realignment of the spine, especially in grade 1, grade 2 spondylolisthesis. We know that not only does regional alignment play a big role in patient outcome, but global alignment does. So if the absence of addressing a collapsed disc and using a facet-only based distractive device, are you fusing someone potentially in kyphosis or malalignment despite having a good neurologic decompression?
Dr. Dufour?
Thank you for the question. I prefer use the facet FFX when the disc height is good enough, but in my experience, for the moment, there is no kypho postoperatively, even if there is 2 to 3 millimeters height. It depends the size of the facet FFX you put in, because we obtain several sizes, and if you use a small one, probably you have a good fusion rate and a good also foraminal reopening, and without any kypho in our experience for the moment.
And also, if I may add on this, I think you raised the question more generally of the sagittal balance and the role of restoring that. And I think it's interesting because in the literature, there is some body of evidence saying that for 1-level, 2-level patient, maybe the restoring sagittal balance is not as important as in longer constructs. So actually, there is some evidence showing that for 1-level or 2-level, it doesn't really make a difference. So in our cases, most of the cases, and in our clearance, by the way, in the US, it's up to 2 levels. So I would say for those cases, it's probably less crucial to restore and think about restoring the sagittal balance than for longer construct with 3, 4, 5 levels. And last also, I also like to think about the alternatives. So let's say we have this stenosis patient. Let's say they have a spondy grade 0.5 or 1. Depending maybe on the countries or the practitioner, some would address that, as we talked about, with decompression alone. So they will not look at restoring sagittal balance anyway. So I think compared to the alternative, we are not making the situation worse, but providing stability, even though the goal is not to restore sagittal balance.
Well, thank you for that. I had a follow-up along the same
Please go
lines,
ahead.
if I can.
Mhm.
We talk a lot about motion sparing versus motion ablating, and I think we're going towards outpatient spine surgery with motion sparing devices. Where do you put your FFX device when you look at the TOPS device that's coming out, or the Phoenix implant that was more motion sparing, sort of facet arthroplasty? Versus, I mean, Dufour had a facet wedge. I know Zygofix has Z-Lock. These are motion ablating devices that are they becoming passe? It's still a fusion. So whether I do a pedicle screw with an inner body, it's a fusion that has an impact on the patient's cranially and caudally. It still is a fusion. So I wonder, even though your rates are low, over 10,000 patients, if you do have a 3.6% decrease in compared to a pedicle screw fixation in terms of adjacent segment disease, that's still a lot of adjacent segment disease compared to what could be the alternative with it, which is in this market, facet arthroplasty or motion sparing. Just wondered what your thoughts were on that.
So first, I want to, of course, congratulate all the other companies making the very hard work in our tough market, because it's very hard to get an implant out there, to get the clinical data. So, I'm not going to say anything bad about other companies out there. What I would say is that we should keep in mind that for our patient population, for stenosis patient, we are talking about 65 plus years old patient. So those patients are not like the arthroplasty patients that have good mobility at every segment, and then you say, oh, but this person is still young, I want to preserve the mobility, etc. We're talking about a spine that is already kind of rigid in those patients. So the philosophical question is, does it make sense to restore mobility at 1 level or 2 level when the rest of the spine is rigid in elderly patients? And I think in our case, this is why it makes sense to consider a fusion and not a motion preserving technique, because we have elderly patients.
Very good. Very great questions, Dr. Khan, and great answers, Camille. Tom, as you look at this young company and the progress they've made so far, and that area in the market that they're targeting with a really innovative product, what kind of questions come to your mind, given all of your experience bringing companies up through this process and getting them to commercialization?
Well, first of all, Dr. Dufour and Camille, thank you for the presentation. It sounds like a very interesting technology. One of the things that I always take a look at from the business standpoint is what's your target market? And one of the things that has developed here in the US in the last 10 years is different than in France or in Europe, is this type of procedure 10 plus years ago was the domain of the spine surgeon. But in the last 10 years, some of these technologies have migrated over to the pain doctors. Have you thought about targeting a specific market. I mean, these two markets to some degree duel with each other. But I think over time, the spine surgeons have accepted that it is going into the pain physicians treating these, whether they like that or not. That is a market that has developed heavily over the last few years. And a lot of these types of procedures are going in there. Have you thought about how you're going to target the market, spine surgeon and the pain doctors here?
Yes, that's the $1 million question, because when you look at the US, for example, stenosis is one of the most common spinal procedure, stenosis decompression, and it's around 300,000 cases per year in the US alone. Now, if you look at the procedure for facet-generated pain in general, like cortisone injection, radiofrequency ablation, it's more than 3 million procedures per year in the US. So we can discuss who should be doing the procedure, but the reality is that at an earlier stage and before the stage of stenosis, today there is a lot of infiltrations that are done with pain doctors and others. So this is the reality of what is happening today. So to answer shortly, I would say that it depends on the stage of the pathology and the indication. If we're talking stenosis, if you need to do a decompression, if you need to really perform a somehow heavy surgical procedure, this should probably be addressed by the spinal surgeon. If we're talking about an earlier stage, where today it's the pain doctors that are doing the radiofrequency ablation or the cortisone injection, it makes sense to consider that those people are also targets of this technique if we can ensure proper training and make sure that it's done under local anesthesia.
That was a very good question, Tom. Go ahead. Do you have a follow-up?
Yeah, well, the reason I focus on that, because I've seen that and I'm working on some companies on that, is I think it will actually impact your distribution strategy in the United States. Okay. The reps that call on the surgeons feel very comfortable talking to the surgeons, and they definitely often don't want to go to the pain doctors because they don't want to in any way upset the relationships that they have with their spine surgeons and vice versa. So that creates another issue to deal with that a lot of companies have had to deal with in terms of, okay, from a distribution standpoint, how am I going to set myself up? Because distribution in the United States is very, very expensive to set up. It's one of the most expensive. I think it's the most expensive aspect of a company is when they're launching and getting the distribution put into place, and how much money that they have to spend is tens of millions of dollars to establish that. And you try to minimize the mistakes that you're making at that phase. So I think this is one of those areas, one is the two market targets, and then how do you approach each target in terms of your distribution model? It would be interesting to understand if you've put any thought into how that is going to be set up.
Yes, I think that's a very important question. And even though I'm based in France, I do hear about sometimes some friendly competitions between the two specialties of spinal surgeons and pain doctors. So, first of all, I want to emphasize again that ultimately what we want is the best outcome for the patient. So this means that whatever the practitioner, we need to ensure proper training. And back to your question about cost, this medical education also costs a lot of money. So this is very important, and we need to make sure that whether it's a spinal surgeon, but also if it's pain doctors, we can ensure the proper level of training. And probably this will require ultimately, both in terms of training and sales, that we consider two distribution channels, one with distributors and sales rep that have a historical network with spinal surgeon, and another one with pain doctors.
Very good question. Looking at the clock on the wall, see, oh yeah, there you are. We've got about 10 minutes left, and and believe it or not, we've got a ton of questions from the audience. So I'm going to jump in and I'm going to ask a couple of the audience questions now. Dr. Dufour, how long is this learning curve for the FFX? Short answers.
Or it takes 3 to 4 cases before to have the techniques in hands. But also, I agree with Camille. It's very important to be informed, very trained. You need a surgeon trick and trips for the beginning sometimes to obtain the good results. And it's the case for every implant, as you know, but I think it's also the case, even if it's quite simple to implant.
Yeah, no, the patient comes first. And yeah, I agree. What are the key aspects or steps of the technique, Dr. Dufour, that the surgeon should keep in mind if they are going to use the FFX? Key steps, key technique.
Put the screw at the end. That's very important. After the decompression, if you need to decompress. Take out the osteophytes, the posterior osteophytes, to be sure to obtain the right positioning of the FFX inside the facet, not inside the bone. So the good positioning is very important. And you can also, with X-ray control, you can have the X-ray control with nearly 30 degrees on one side and 30 degrees for the other side to obtain the good positioning or the good control of the positioning of the implant. That's 3. And the best one is very important. It's a good indication.
Oh, for sure. Of course, which actually, go ahead.
If I can double down on that,
Yes.
is that I don't know if you have in mind the picture that Dr. Dufour showed on the facet degeneration in his case. So you can see that the facet joint line was really curved, right? So the question might be, how do you put a straight implant in a curved facet joint line? And this is exactly what Dr. Dufour emphasized, is that the first step is to remove all the bone spurs. You remove all the bone spurs, the arthrosis, and then you're only left with the true facet joint line, which is straight. And then you're rasping with the instrument, making the proper space for the facet cage shape. And you have then a straight facet joint line with a straight facet cage.
Wonderful. Okay, we actually only have time for one more question. And let's see here. I think this is a pretty good one. And again, this is going to go to you, Dr. Dufour. You're getting all the main questions here. In your experience with your patients, how prevalent is facet joint pain? Is it, and maybe give it a comparator somehow with disc generated pain. Dr. Dufour?
We have nearly 50% of the patient with facet syndrome. If you look at clearly, you can find it. And I think it's underestimated for the moment because not so well known. We have to focus on clinical signs to try to find who is guilty in terms of pain generator.
I wish we had more time. I think we could go another hour, honestly. There's just so much to go over. And you're nodding, Dr. Khan. I know you have a lot of questions. I know you do too, Wade. And Tom, we could go on forever about how this integration between markets is actually going to happen. It's a great topic right now. This sort of, maybe it's a transition. I'm not sure. It's certainly a great topic to discuss between the interventionalists and the surgeons. We could not have asked for a better panel this evening. I am just delighted all of you were able to participate. This is a terrific technology. Camille, again, I'll echo what Wade and Dr. Khan and Tom have said. Congratulations on really great job you've performed in bringing the company to this level. this is, I hope you, the audience, learned a lot. I know I did. And this, again, is a topic that will be the subject of a lot more discussion, I am sure. This is all being recorded, and we'll be posting this on our YouTube channel. Feel free to come back often because there's a lot of stuff you're going to learn. You want to listen to it again and again, I'm sure. So again, thank you all, Camille, Dr. Dufour, Wade,
all.
Dr. Khan, and Tom, and have a great rest of the day, everybody. Thank you again.